Antimicrobials are the leading things that we know, and antibiotics are the ones that we use on a daily basis. It can be in the community, it can be in the hospitals, it can be anywhere. And why these topics? I know there are clinicians, but some of the companies will be reaching out to the clinicians, and this topic is very crucial to all the levels in the healthcare society, including the representatives, including the companies as well, that why this antibiotics I'm focusing on, and what kind of questions that you may encounter on a day-to-day basis, and what are errors. You can understand any kind of fault or defect that can be classified as an error. It can be a human error, it can be an error from the quality of the product, or it can be multiple things. So we'll be going through all this. So basic terms that you need to understand over here: what is an adverse drug event, what are this, and this is basically just having a incident where the medicine will cause to the patient directly or indirectly. And an adverse drug reaction is a reaction that is unexpected and unintended towards the patient. So antibiotics are very commonly known to cause adverse drug reaction and events in this matter. So what is medication error? If we can understand, it is a failure in the treatment process that leads to or has the potential to harm a patient. So everyone goes to the hospital to treat themselves, to get a cure for their condition or their illness. So an error can cause a patient harm and even death. So medication errors are one of the leading cause of hospital acquired injuries or hospital stays increases due to medication error, or even sentinel events, which we call, where the patient loses their life due to some kind of mistake. So these mistakes can be associated into multiple levels, from the consultant to the nursing to the pharmacist. Every level, everyone is included, because we are dealing with lives over here. And nearly, if you ask the global scenario, it is around 30 to 40%, means 4 out of 10 patients will have any kind of medication error. And if you ask about India, it is more than 50%. So every 5 out of 10 or 1 out of 2 cases will have some kind of error that has the potential to harm the patient. So there is a human consideration that we need to consider, that as we are dealing with lives and multiple healthcare professionals, so it can be due to a mistake from someone that will cause or harm the patient. So we all expect patient safety and patient well-being, right? So multiple time lack of knowledge, lack of uh, consistency in the upcoming days is also a very challenging thing. And human errors are very important, because mainly we see it can be from the doctor's end, from pharmacist end, because day by day we are having newer medicines, newer combination. How to give the medicine properly to treat the patient is very crucial. And having that human factor, why does this happen? What is It is mainly due to the knowledge base, or there are lacks of in the skills, or in the system we can define as policies, that how it has been handled or how it has been stored. This all comes under the system and the policies and the regulations of an individual institution. So I won't be going much into that. So just feeling overwhelmed, if you are a junior, if you have joined into this healthcare society, you can be overwhelmed with so many things. Lack of knowledge and awareness is a very significant issue. So what are we dealing with? Remember, not a behavioral choice, it's just an error. It can be due to multiple cause, and the best way to manage human error is to examine in the system and console the individual. So you have to identify what is the problem in this one, where is the problem, and where does we lag in this one. So this is a basic sense to it, and how we can avoid it: by having rules, policies, education, and vigilance. So these are all theoretical things. The major things into a medication error is, what are the leading cause? It can be a prescribing error, which can be a wrong dose, communication with the orders, preparation of the drugs, administration, and monitoring of the drugs. So it will be in any of the steps we can see. The one we call as a near miss, if we are able to prevent it, the error or the harm is not going to the patient, we have prevented in the midway. It can be due to illegible handwritings. I know we doctors have a very good tendency and a very beautiful handwriting at times that only the pharmacist or the stores can only understand. I will not blame everyone because sometimes illegible handwriting is the cause for the wrong drug or the dose. Underdose or overdose is a very big thing over here because we don't do a very rational drug dosing as per the body weight, which is quite a bit required because we are having fixed dose combinations and multiple things over here. Incorrect drug information. There are multiple levels that the drug informations which are provided are incorrect. So this is a place where misconception happens and it leads to potential harm. Monitoring error, I'll be going down deep and discussing, and compliances error, not following the protocols or rules properly will lead to this kinds of error. So in a corporate hospitals like in India, we follow the NAB standards for all these protocols and how to develop the multiple national international guidelines to support alongside. So improper storage, incorrect preparation, illegible handwriting, incorrect strength or dose, incorrect form, incorrect infusion rate, incorrect timing, inaccurate or insufficient patient history, and presence of known contraindication. These are the majority of the things that we need to look into a medication error. So improper storage, if you ask me, storage of drugs is very crucial. Supposedly a drug is manufactured at a plant and the molecule requires a stable, controlled environment. Like it should be protected from light, the temperature should not go above certain levels. So this needs to be carried out throughout the process from being manufactured to receiving at the end user, which is the patient, and before the administration. So all the healthcare providers associated, being the pharma company, being the vendors, distributors, supplier, to the procurement team, to the pharmacy, then going to the wards, and particularly at the end to the patient. This is very crucial because many of the drugs are light sensitive. They will deteriorate if it is kept under or exposed under direct sunlight. And multiple times, antibiotics are the primary thing that deteriorates easily, followed by blood products like albumin or even immunoglobulins and other products. And chemotherapy drugs are very much well known to have this kind of effect. So we will see discoloration and other associated complications if storage are improper. One of the major drugs is insulin, where we see if it is not stored properly, the insulin efficacy and the potency decreases. And even filgrastim and other products like that is also very much sensitive to the proper appropriate storage. Incorrect preparation, we don't prepare the drug. The drug has been prepared by the companies and we reconstitute and give it to the patient. So how it can be there? The multiple times I have already shared the beautiful handwritings make this kind of errors, and already the National Medical Council have given guidelines on how to write a prescription, and we also follow the ISMP guidelines for this. But still, we have a long way to go and conquer in this one. Incorrect dose, strength, incorrect form of drug, and timing. The one complication that I have heard with the newer antibiotics is the dose. What to give the dose, how to titrate. Supposedly, if we ask a common drug like a carbapenem, supposedly if we talk about meropenem, so what will be the dose? If it is a 1 gram formulation, if the patient is having normal kidney function, then it will be every 8 hourly or thrice daily. So 1 gram thrice daily is the ideal route for any kind of gram negative infection. So what will be the dose if the patient is having meningitis? Will 1 gram be sufficient? No. If the patient is having meningitis, then the drug needs to reach to the cerebrospinal fluid or it needs to cross the blood-brain barrier. Meropenem is not that much good having penetration into the blood-brain barrier, so you need to give on a higher dose, which is recommended in 2 grams. One of the newer drugs is ceftazidime avibactam, if I talk about. So what is the dose for that? It is 2.5 gram thrice daily, which is 8 hourly frequency. And if the patient is having impaired kidney function, then the dose is titrated and modified accordingly. But what does this ceftazidime avibactam combination comes with? It has 2 grams ceftazidime and 500 mg of avibactam, which is a novel drug, and it is very much effectively used in multi-drug resistant gram-negative bacteria, supposedly for Klebsiella. We can't use ceftazidime avibactam as a treatment of choice for Acinetobacter infection, and incorrect timing. So the timing is very crucial. If it is a thrice daily drug, it has to be in a frequency of 3 divided dose into 8 hourly difference. Like the first dose, if you are giving at 10 o'clock, the second dose should be having a difference of 8 hours in between. So inaccurate or insufficient patient history. We have to take very good history for the patient, because we need to find out what are the previous histories, whether the patient is exposed or having allergic reaction to any of the drugs, or any contraindication, comorbidity, or travel history, as we all are suffering and have exposed to COVID-19. So that gives us a very clear example on for how important is the travel history and what is the exposure history. It's very crucial to take, because there are multiple infections that are coming in, and we need to be very much careful about it. And hospitals are having very high rates of hospital acquired infection, and those are all multi-drug resistant organisms, the one we call as superbug. Presence of known contraindications. So there are multiple times where the patient is already having some kind of contraindication. Maybe it can be a disease contraindication, it can be a drug contraindication. Disease, supposedly if the patient is having sepsis, and the contraindication can be hypertension or even diabetes mellitus. So patient having ARDS is already having diabetes mellitus, we are very much contraindicated to give steroids to the patient, because we need to steroids will be increasing the blood glucose level. So it's very much vigilant that we need to know. And sulfur drugs are something that is also considered to be very much potential on this. So how we can prevent medication error? Providing the right drug information, and it is very crucial, because a new drug comes into the market, the first thing the companies will be going to the physicians and will be showing what is the information of the drug. That is where you need to have clarity on what the drug will act on, how it will act on, and what is the potential effect of this drug. I have heard multiple times where it has also been told to me by a medical representative that you can use ceftazidime avibactam for the treatment of Acinetobacter, and I firmly reply that no, we can't use ceftavi for treating Acinetobacter baumannii infection. It only covers OXA 48, NDM, VIM. I know many of the people won't be knowing all these terms. What are these? This is very much crucial. You need to understand when you are approaching a physician, you need to give the accurate information on what is the drug, how to be used, and what are the things need to be considered. Apart from the price and all, this is very much crucial. Patient profile is very much important, whether weight, pregnancy, or renal impairment and other conditions need to be very much looked after. And what is the profile of the drug? What is the dose? What is the frequency? And what is the efficacy of the drug? Certain drugs will cross and will be working in certain kind of infections and certain kind of organisms only. So we have to be very much caution, because antimicrobial resistance is something that we are dealing with it on the daily basis. Prescribing errors we commonly observe with the dose, the varying dose. Multiple of the times the dose are very much incorrect if we consider the junior doctors, but the senior clinicians are very much seasoned and knows how to do it and what are the correct dose. Writing a prescription is very complex actually. Giving the perfect drug to the perfect rational use is very much there. Like supposedly, if you take an example, many of the times we won't consider before using any oral antibiotics, we won't consult a doctor. Like using azithromycin or azithral or even doxycycline is very much rampant post the exposure of COVID-19. We just take these antibiotics just like we are taking chocolates or toffees. So this shouldn't be the case because azithromycin and doxycycline are the only drugs that will act on certain kind of infection, supposedly scrub typhus. Scrub typhus treatment calls for azithromycin dose only, but now we are getting resistance from azithromycin, so we have to use azithromycin and doxycycline to treat that kind of infection. We don't have any other drugs to treat that infection, so if we use this oral antibiotics rampantly, we will be having the resistance and it will be further complicated and we won't be getting that good efficacy. So prescribing, if the doctor is prescribing you an antibiotic or any other drug, you should check by yourself and ask the doctor for how many days, how to take, what are the things to avoid. So it's very much important that you should know about your drug when you need to take, what are the things you need to avoid during this course of therapy. The wrong dose, the frequency, and duplication of therapy. This is very much common. The dose is wrong. Supposedly, if a patient is obese and requires paracetamol for the fever, 500 mg paracetamol won't be sufficient for him. So, as per the dosing frequency, he needs one, or he or she needs 1 gram of paracetamol. Suppose vice versa, if a 40 kg patient is advised with paracetamol 1 gram, the patient will have injury to himself. So the dose needs to be checked out, the frequency, that how many times we will be having in a day, and whether the similar type of drugs are given or not. It mainly happens with antibiotics in the hospital. We call this as therapeutic duplication. The patient is receiving same category of antibiotics, the duplication, what we call as. So these are all the examples where you can see that multiple type of DVT prophylaxis or any kind of antibiotics has been duplicated in the time of the hospital stay. So these are the errors that we observe, and one of the usage of error prone abbreviation, having the correct abbreviation which we call as a unit. If a dose is on ml, you have to mention as ml, or if it is at units, it has to be mentioned in units. You can't use error prone abbreviations, and using decimal points is very much crucial where the decimal is there. Supposedly, if I am writing 2.5, it means 2.5. If the decimals goes one step ahead, it will be 0.25, and if the decimals goes behind, it will be 25. So these are the common things that needs to be taken care of, because we have encountered multiple errors just due to this, where supposedly a dose was to be given 7.5 mg, the decimal got wrong and the patient received 75 mg, which was 10 times, and the patient had uh, hypernatremia and the sodium level skyrocketed. And thankfully, the patient was managed conservatively and there was no harm to the patient at the end. So, when to start a medication, during the medication, adding a medication, reviewing the medication, and stopping the medication. These are all very important. We have a tendency of not completing the course of therapy as advised by the clinicians. So, please adhere to that. If a drug is given you for 5 days, 10 days, or month, or to be continued, please adhere to that, because your body will be responding on the way you are taking the drug. If you're not completing the therapy, you can have much more complications in the upcoming days. Supposedly, if you are having stomach upset, taking metronidazole or metrogyl once or twice is not sufficient. You have to take the entire course of the drug, otherwise it will get resistant. So WHO excuse me, has shared this five moments for medication safety over here. That is for your referral. Verbal orders are the things that a drug is ordered verbally, and multiple of the hospitals have policies on how to adhere to this and not having a verbal order policy. Or in case of emergencies, it needs to be read back. to the physician to consult. The multiple time the pharmacist also makes errors where it is known as dispensing error, dispensing the wrong drug or the wrong dose or the wrong dosage form is present, and this can lead to a casualty. And the dispenses happen and reach to the patient, and if the nurses catches this, then we call this a near miss incident. And if it is not prevented, it reaches the patient, and the patient might get harm. So pharmacists, technician, nurses, everyone will be adhering to this, and there will be a separate section for similar looking drugs or the drugs that have similar names. So we will be having this kind of errors over here. So this is very much common, and the technicians and the nursing staff, everyone is involved in this. So all the hospitals are now following this LASA drugs, which is look alike, sound alike, and they will be having their own list depending on what brands they use. So double check the prescription before dispensing the drug, and if the patient is able to take it on their own, they should also check whether which drug they are taking. So recently there was a headline where vecuronium was given instead of midazolam just because of this lookalike, and pegfilgrastim was given to a patient instead of filgrastim because of their lookalike. So this was a dispensing error that has reached the headline, and this was taken place in the US in 2017. And the pegfilgrastim incident was a very major one where it was given to an Air Force veteran, and it developed to a pulmonary toxicity for the patient. So these are multiple case reports that we will see that dispensing error caused to the patient, and this patient also was hospitalized with hypertension and acute kidney injury and was given amlodipine twice daily, but it was something that the brand was a misconception, and the patient got thiotixin instead of amlodipine. So errors in the administration of drug is the last point where we can prevent the error. If it is administered to the patient, then the error reached to the patient. So the drug name, what is the drug appearance, what is the indication, everything needs to be considered and has to be given in a proper rate. So what kind of administration errors? I'll show you. Do you think that this is an error? It's a well-known drug antibiotic, which is the second generation cephalosporin, and it is used as a surgical prophylaxis. So the reconstitution needs to be proper with the appropriate diluent using the right amount of reconstitution. You can see in the picture that it was not the right diluent and not the right quantity of diluent. So if you talk about cefuroxime, it needs to be diluted in sterile water for injection instead of normal saline. In the hospitals, you will see this kind of practice that using normal saline, and this in this case it was used 10 ml. So you will see that it has not properly dissolved. If you use 20 ml, which is the appropriate number, you will see it will have dissolved properly. Similarly, using the right diluent is very important. Which drugs needs to be reconstituted in what? Supposedly normal saline or sterile water for injection is very crucial. And administration like ceftazidime, avibactam, and astronam. How long it should be given, whether it should be given simultaneously or should be given one after the other. It should be always given together to get the astronam avibactam effect over a period of 2 to 3 hours at least per infusion. Carbapenem should be given at least for an infusion of 3 hours, whether it is meropenem, artepenem, any of the carbapenem, because if you give it in a short dose, the patient might experience convulsions. Similarly, for polymyxins, test dose should be given, which is a loading dose, and it should be given the appropriate amount. So if it's colistin and the patient is having normal renal function, it will be 9 million units, and for polymyxin B, it will be 15 lakh units. So this is one of the errors I will like to highlight. In this case, if you see the left-hand picture, it is injection clarithromycin, which was reconstituted with normal saline instead of sterile water for injection, and the drug will formed chelating. So when you give this to the patient, it will irritate the patient, and you will think that this is a drug reaction, but no, because of this error, the patient might experience some kind of reaction. So using normal sterile water for injection for clarithromycin is recommended. These are the points that you need to look. And one more thing, if you're not using the proper amount, you will have dark color of the cefuroxime. You need to use 20 ml, then you will find the light golden color. Otherwise, multiple of the times you will receive this complaint that it is too orangish or dark color because it was not reconstituted properly. So this is one of the examples that you will see on a day-to-day basis. Then skin test. Multiple of the times you will see that to do a skin test before starting an antibiotic. I'll say don't use skin test. It was identified in the year 1985 where the T cell reaction is noted for penicillin. It is ideal for penicillin, penicillin G kind of reaction, but using a slower infusion will help the patient better. How? Just prepare a small amount of the drug, use the IV infusion set, how it is given. Give a very small dose, supposedly 1 ml of the drug. Observe for 10 minutes. If there is no reaction, then you can slowly give it as per the instruction given by the physician. If you give uh, all this kind of antibiotics through a skin test, you will find sometimes skin necrosis because multiple of the drugs are known to do this. Supposedly vancomycin, in this case, this was liposomal amphotericin B, was given as a skin test, which is not recommended. So patient will have this kind of necrosis. So switching on to a slow infusion test dose is better than the traditional uh, skin test, I'll say, and it is much more efficient and better, clinically proven nowadays. So these are the administrating facts that I have shared with you, how these drugs were considered as errors, but these are not errors. These are the human involvement. The lack of knowledge is very much present, and updating this knowledge is very crucial. You will be finding this kind of queries on a day-to-day basis. I have also reached out to your colleagues as well that why this kind of problems happened, and then we had a discussion on how this was a human error rather than a manufacturing defect. So monitoring it as how having the proper monitoring during the hospital stay or post hospital stay, also monitoring your vitals or the parameters as per the recommendation of the consultant is very important. If you don't have any comorbidity or any of the disease, a healthy person should evaluate themselves yearly once at least. And if you have any complications, supposedly hypertension, diabetes, or you have a family history of hypertension, diabetes, it needs to be checked every 6 months. At least your BP and your blood sugar levels needs to be checked every 6 months. So if you don't monitor properly, there will be chances of this kind of complications further down. So, when the error occurs, how you rectify it? First, you have to detect what is the error, what is the problem. Then do a thorough root cause analysis. What is the problem lying under behind, and what can be the corrective action, and what can be the preventive action from the further steps. So the review needs to be done properly, and the patient needs to be monitored thoroughly if there is any harm to the patient or not, and continuing surgical sponges and counting surgical sponges if it's a procedure done to the patient, because multiple of the times there are case reports where the surgical sponges were left inside the patient, and